started with some questions. The thyroid gland, we'll talk a little bit about the diseases and disorders that affect the thyroid gland. So we have the hypothalamus here, the hypothalamic stalk, hypothalamic pituitary stalk, the pituitary, anterior and posterior. And the hormones that are the hormone for the thyroid gland that is reduced from it is the anterior pituitary is going to be this hormone called TSH. And TSH is reduced into the bloodstream, and then that will affect downstream the thyroid gland located in the neck. The thyroid gland will then release these hormones, T4 and T3. So the disease processes that you will see, that you will diagnose and treat, are related to TSH hormones, T4 and T3, which are what we refer to as thyroid hormone. When we talk about thyroid hormone, we're talking about these two. These hormones are regulated normally by TSH. TRH, thyroid releasing hormone, will affect thyroid stimulating hormone, and then thyroid stimulating hormone will increase the production of thyroid hormone, aka T3 and T4. But when you have interruptions in this pathway, you can have an increase in TSH, which will lead to an increase in thyroid hormone. You can also have other sources of TSH that can then affect the thyroid gland and lead to an increase in T4 and T3. You can have tumors that form in the thyroid gland that can lead to increase in the production of T3 and T4. And so depending on where the pathology is will determine what you see clinically. Will you see a patient that has symptoms of hyperthyroid disease, or will you see symptoms of hypothyroid disease? Both of these hormones, T3 and T4, affect the metabolic rate, your heart rate, weight loss, skin conditions, anxiety, anxiousness, because elevations in these hormones will increase your metabolic rate. It can also affect brain function. It can even affect lipid and carbohydrate metabolism, further affecting weight loss. The other hormone that's produced by the thyroid gland, referred to as calcitonin. But calcitonin doesn't have a role in metabolic rate. But its role is in regulation of calcium. And it really regulates calcium in pediatric patients and adolescent patients. Calcitonin doesn't have a major role even in calcium metabolism, except in the young. Calcium metabolism is really affected by parathyroid hormone. So that being said, if you get a question about what hormones are produced by the thyroid gland, you need to remember that it's T3, T4, and calcitonin. Diseases of the thyroid gland. The patient will have symptoms of hyperthyroid disease. What are some symptoms that you can think of that characterize patients with hyperthyroid disease? Enlarged thyroid gland is often a characteristic of hyperthyroidism. Now, enlargement of a gland does not always reflect hyperthyroid disease. You can have benign situations where the thyroid gland is larger, and that can be familial, or it can be due to other disorders that affect the gland, and the patient is not hyperthyroid. In fact, the patient can be hypothyroid, or they can be euthyroid. Now, the bulging eyes is associated with a very specific condition that all students have to know about, and that's Graves' disease. The Graves' disease has a very specific pathology, not only because of the presentation, the way that the patient looks. It's diagnosed and recognized typically. The patient presents with symptoms of hyperthyroid disease. Pituitary tumor is another source of hyperthyroid disease. And These three, in large part, are the ones that you were going to be asked. Graves' disease makes up 75% of the cases, so you can certainly expect to see a question on Graves' disease. The other cases that you see, toxic nodular goiter, they are cases that you will see in the community that you will diagnose. Pituitary tumors are relatively rare. You may never see one of these, but sometimes they show up on exams. The way that hyperthyroid disease is typically confirmed is by doing a laboratory serum level of T4 or T3. Some patients will have both hormones elevated. You're measuring thyroid hormone. T4 is elevated, that tells you they're hyperthyroid. If T3 is elevated, that tells you they're hyperthyroid. Symptoms related to elevation in T3 or T4 are the same, and that is this hypermetabolic state. Typically in these patients, because of the negative feedback effect of thyroid hormone, you're going to get a decrease in TSH. So here you can immediately see a way of separating a condition that the source is the pituitary gland versus the source being the thyroid gland. If the source of your pituitary disorder is the pituitary gland, then you're going to have an elevated TSH, result in an elevated thyroid hormone. Your pituitary gland is normal, but your disease is a tumor in the thyroid gland. Now we have that autonomously secretes T4 or T3. Now we're going to have a negative feedback on the pituitary gland. And so because of that, the thyroid hormone is telling the pituitary gland to slow down. And so we're going to have a decrease in TSH. So we measure, and typically we measure T4, you still don't know the source. You don't know if your source is from the thyroid gland or if the source is from the pituitary. But if you check the TSH level and the TSH level is low, then you know that your source is indeed the thyroid gland. Typically the first test that we do to measure T4 and TSH, we typically don't do one or the other. If you are assessing a patient for a thyroid disorder, you're going to check these two labs. And that will secure the diagnosis. What are some physical signs the patient comes in? What makes you suspect that they may be hyperthyroid? You're going to check their thyroid. Is the thyroid enlarged? If the thyroid is enlarged significantly, then we would define them. We will say they have a goiter. And that's your first sign. But sometimes goiter is subtle, that it may be small. It may just be a little bit enlarged, harder to detect. You may not notice it, but the patient may have symptoms. If the patient doesn't have an enlarged thyroid gland, but maybe they're complaining of unexplained weight loss, nervousness, palpitations. You check their blood pressure, they have an elevation in blood pressure, maybe a little bit of difficulty sleeping, because these patients, since they're hypermetabolic, they tend to be anxious, weight loss, insomnia, maybe a little bit of intolerance to heat as well. On physical exam, you take your reflex hammer and you assess for them for reflexia. And if they are hyperreflexive, then now your suspicion is significantly elevated and you think that the patient may have hyperthyroid disease. The question now is, what is the cause? Do they have Graves' disease, which is an autoimmune disease of goiter, toxic metabolic or toxic nodular goiter, where you're going to do an ultrasound of the thyroid gland, and vascularity of the gland is not something you'll pick up on physical exam. It is something that we'll typically pick up on ultrasound. And exophthalmos you may detect in patients that have advanced disease. So the textbook picture of the bulging eyes, that is typically in a patient who has not been treated for her Graves' disease, his or her Graves' disease, and they've had it for some time. And if it does go untreated, because the antibodies affect not only the thyroid gland, but they also affect proteins in the eye, then these patients will have this condition of exophthalmos. But hopefully it's diagnosed before patients have this manifestation, which can be difficult to treat, but it is a late finding, and it's always the finding that we see in the textbook. The acute intervention is you want to prevent fibrotoxicosis. This can be life-threatening. The treatment, when you assess and determine that a patient has thyroid storm, is to admit the patient. They need to be placed on a 24-hour cardiac monitor and observed for dysrhythmias, and those would need to be treated if they are at risk. They need to be placed on oxygen, IV fluids, electrolytes will need to be managed. They would be NPO for a period of time until their thyrotoxicosis is managed. Ideally, you want to maintain a calm environment. This is pretty specific to Graves' disease. I care for exophthalmos, which is tears, salt restriction, keeping the head of the bed elevated and protecting the periorbital area. Graves' disease patients can certainly have thyrotoxicosis in an advanced state. So thyrotoxicosis isn't unique to Graves' disease. It's just thyro meaning thyroid and toxic meaning they have a severe elevation in their thyroid hormone that's causing these metabolic symptoms. This can result from Graves' disease, but it can also occur in thyrotoxicosis or a patient with a toxic nodular goiter. So it doesn't have to be an autoimmune Graves presentation. You could even have thyrotoxicosis as a result of a pituitary tumor. It simply requires marked elevation in these thyroid hormone levels, and these patients will have these symptoms. The collaborative care involves medication. Treatment with medication for hyperthyroid disease is extremely effective. Once you make the diagnosis, typically we would start the patient on PTU, which is protothyroid uracil, or tapazole, which is an alternative. It's a little bit, choice of the endocrinologist that's treating the individual, whether they like PTU or whether they like tapazole. But both of these are very effective. It takes a little bit of time for these to take effect, anywhere from 2 weeks or so. But slowly the gland will shrink in size and the symptoms will resolve. While you're waiting for PTU.